Welcome to CSIS Online. The way we bring you events is changing, but we'll still present live analysis and award-winning digital media from our Dracopolis Ideas Lab, all on your time, live or on demand. This is CSIS Online.
Hello, everyone. My name is John Hamre. I'm the president of the Center for Strategic and International Studies, which is a think tank here in Washington, D.C. This is an unusual thing for us. We are trying to talk to professionals in healthcare throughout America. You know, there's an old joke in Washington that Washington is 10 square miles surrounded by reality. And we came to realize that was not just a joke. This last year, I think all of us have come to realize that this is such a vast, complex, dynamic country, and the perspective from Washington alone is inadequate. We realize that there's so much we don't understand in Washington and that you are living through every day. This is an effort for us to both listen and to share with you insights from remarkable experts. And I'm just so very, very pleased that Peggy Hamburg and Asaf Bitton are with us today to share with you some thoughts. And then frankly, we hope that it will enlist some of your ideas in the process. Steve Morrison heads our public health program at CSIS, and I'm going to turn to Steve to run this program for all of you, and I'll be listening in with you. Very much look forward to hearing from you and your reactions. Steve, let me ask you to get this program going for real.
Thank you, Dr. Hamre, and welcome to everyone. This program today is part of a commission, a CSIS Commission on Strengthening America's Health Security. We founded that commission 3 years ago, this coming April, and it's been very, very active since then and will continue its work through 2022. And we have with us today two very active members of our commission. Dr. Peggy Hamburg, who's an internationally recognized leader in public health and medicine and who currently chairs the NTI, the Nuclear Threat Initiative Bioadvisory Group. Previously, she was Foreign Secretary of the National Academy of Medicine for 6 years in the Obama administration. She served as the Commissioner of the U.S. Food and Drug Administration and previously served as the New York City Commissioner of Health. Welcome, Peggy. We're also joined by Asaf Bitton, another member of our commission, who is the Executive Director of the Ariadne Labs in Boston. And he has led efforts both globally and nationally to transform primary healthcare delivery systems and how to create high quality integrated healthcare models. He serves also as an assistant medical director at the Brigham and Women's Advanced Primary Care Associates, and previously a leader of the Primary Healthcare Performance Initiative launched in 2015 at the United Nations. We at the Commission, the CSIS Commission on Strengthening America's Health Security, we pay predominant attention to international issues, but in the course of this pandemic, we could not turn our attention away from the pressing domestic issues. And so we have really made this an additional top-line priority of our work, and it remains so. And so today we're coming to discuss big issues around rethinking U.S. health systems after COVID-19. I'm going to ask Dr. Hamburg to open up momentarily, followed by Asaf Bitton, and then we'll have a conversation among ourselves. We've received a few questions from some of those who are participants in this network. Peggy, as we move beyond the acute phase of COVID-19 pandemic, and as we begin to implement the public health reform measures contained in the American Rescue Plan, the $1.9 trillion package, how do you believe relations between federal and state, local levels, public health agencies, how do you believe they will evolve? And is this now driving a new national debate about the balance of authority between the federal and state levels? Thank you.
Well, thank you, Stephen, and thank you for including me in this session. Such an important topic, such a critical time. Just to begin, I think we all recognize that the COVID-19 pandemic has really changed a lot, bringing attention to public health in ways that really never before have happened. In many respects, the pandemic has brought to light the critical nature of public health and its work, the public health infrastructure and our chronic underfunding of that infrastructure, including the workforce. But it's also, I think, really underscored the essential role public health plays to prevent and mitigate the spread of infectious disease threats. And also, the pandemic has really underscored the social, economic, and cultural conditions that shape the health of populations. Overlaid on this, of course, was the civil unrest and societal reckoning with issues of racial inequality that came following the murder of George Floyd and other tragedies, and really has further highlighted the deep-seated issues of racism and racial injustice that have for centuries shaped health and that are at the core of much of the work that public health is trying to undertake. We have seen during COVID the many pressures on federal and state health departments that have struggled to respond and to provide much needed leadership, and the challenges of working at the interface of public health, science, medicine, and politics, and the complex challenges of our federalized system for public health, where we have power and authority residing at different levels, from the federal through the state to regional and local, which adds strength in certain ways, but also fragments capacity. And during COVID, we've seen tensions and conflicts between public health and other sectors of society, including politicians and the public, that I think we never expected to see. So it does bring into stark relief work that needs to be done going forward. It certainly is an opportunity for public health to think about where it is and where it needs to be in the future, both to address pandemic threats such as COVID, but also to better achieve our routine activities. So just a couple of thoughts there, really getting at your question, Steve. I mean, first, I think this is an essential time for us to recognize that we have to more adequately invest in public health. I have seen improvements since I first started working in this area. It used to be less than 1% of our very large budgets for healthcare in this country. We're now up to, I think, 3.6 trillion for healthcare overall, and about 3% going to public health. But that is not enough, given the critical position in which public health sits and the crucial and unique role it can and must play. Also, we need to develop the workforce. We know that in recent years, there have been very dramatic declines in public health workforce, especially at the local level, and that is not acceptable when we look to the future and as we think about what is needed as we speak to respond to the threat of COVID-19. I think this is a time when we have to, as a society and as a public health community, really be willing to take a clear-eyed look at how we deliver public health. We have to think about a more integrated system. The kind of fragmentation that we currently have doesn't allow us to leverage resources, human and dollar resources, as adequately as possible, and to really reinforce and strengthen and extend critical public health activities. So I think we really do need to look at the public health system as it currently exists and be willing to think about substantial reforms to the organization of public health. We also have to think about how public health fits into a broad continuum, linking and integrating much more closely with systems of actually delivering health care, but also into the community to address social determinants of health that make such a difference, and activities that occur outside of the healthcare system for sure, and outside of public health, but need to be embraced into a sort of an integrated whole. We really need to upgrade the technology and capabilities of our health departments as well, really learning from some of what we've achieved during COVID in terms of digital tools and technologies. We need to strengthen IT capabilities and data collection systems, making sure that we can have closer to real-time information collected, but that we also communicate that information in ways that make it not only data collected, but data that can be acted on in meaningful ways. We need to strengthen fundamental competencies of public health, surveillance, laboratory capacities, things like contact tracing, of course, as well, and so many other systems within public health. And we need to really continue to build on how we disseminate information, how we get information out to all the stakeholders who need it, and how public health leaders can communicate in clear, consistent ways with the public and with policymakers. So there's a lot on the agenda, but a lot of opportunity and more, I think, commitment and appreciation of the role of public health than ever before. Thank you.
Thanks so much, Peggy. That was terrific. I'm going to turn now to ask Asaf Bitton. The big question is, what has the pandemic revealed about the fragility of state and local health capacities? And how far, in your view, does the American Rescue Plan go in addressing the sources of the fragility? Peggy's touched on many of those factors, but I know this is something that consumes your attention day in and day out. What more may be needed, and how is the debate about resilience and fragility evolving as you see it in your work that carries you all across the country?
Well, thanks so much for the opportunity to be here, and thanks to Dr. Hamburg for her comments. The lens through which I'll share my comments are really threefold. Really, number one, through the lens of being a primary care physician, a frontline healthcare worker during the pandemic. Number two, as a public health researcher and leader. And then number three, through my work at the Center for Medicare and Medicaid Innovation on thinking about how we structure care delivery and payment models to try to, as you said, promote resilience and stability and perhaps reorientation of some of our healthcare system. So, just building off of what Dr. Hamburg was talking about, it's clear that COVID clearly shined a light on inequity, not just in terms of who gets care, who gets testing, who is left in and who is left out of our healthcare system, and the what shouldn't be shocking disparities, but nonetheless frightening disparities in terms of those most affected, those communities most affected, and who continue to be affected. I mean, this isn't just a story of last year, but I think that one of the things I can say is, as a frontline provider is especially in the primary care realm, is the fact that this lack of coordination, not just at a national and state level, but at a local and almost community and neighborhood to neighborhood level, when faced with a health shock as severe as a pandemic, especially in the early phases, not knowing who would have enough PPE, how to get PPE, where to get the critical testing that our communities were demanding and needing in order to literally survive and figure out quarantining, understanding how to roll out quickly, not only telehealth initiatives, but really defining resilience as the maintenance of essential healthcare services and how to maintain those healthcare services in the midst of an absolutely frightening pandemic, in which, though the understandable and appropriate focus has been on hospital care and our ability to provide the acute care necessary to help the thousands and millions who've been affected by severe COVID, I think what we see in COVID is what we knew about the US healthcare system, which is that we do rescue care really well. Our ICUs are incredible. Our hospital systems are incredible. With a few examples at critical moments in the pandemic, the hospital systems managed to find ways to not be overwhelmed like they had been in other countries, to perform admirably and to innovate and find new treatments to really reduce the mortality of this severe disease. The other side of that coin, though, is that with all that emphasis on rescue has come a lack of emphasis on promotion, prevention, public health, primary care. What are the struts and the infrastructure and capacities within and around our healthcare system to promote health and to not just rescue people once they're acutely ill? And so I think that that's a real opportunity and an area that we can and should focus on moving forward in restructuring our healthcare system, rebalancing rescue and prevention, rebalancing acute and chronic care, and really rethinking about the other part, I think, lessons of COVID, which is what is the social compact necessary in and around our healthcare system to promote health in our communities? It's not just the politicization of scientific fact, truth, and public health strategies, but really this idea that if we are to get at the core of the issues that we face to promote health equitably across the country, then we have to have a discussion at all levels about the social compact necessary to act together for the common good. And that has, I think, we have not done a great job of that. We can barely agree that people should wear masks, and we can barely agree in many parts of the community discussions about vaccine confidence. And so we have a lot to rebuild in the sector of trust. And in using the trust dividend that particularly important parts of community-based public health organizations and primary care organizations who have loci of trust, using that to rebuild moving forward. The second part of your question, you asked what's in the American Rescue Plan, and I'll just be brief to talk about the highlights. There's a lot in the America's Rescue Plan about COVID recovery. There's at least $93 billion that's been allocated, in addition to important provisions around making marketplace and public health insurance more affordable through the ACA, as well as providing new incentives to states that have not yet expanded Medicaid. But some of the highlights within the bill that are specific on COVID relief, there's almost $50 billion to HHS for testing, contact tracing, mitigation, and surveillance in communities, including development of what we really need, which is a national evidence-based strategy at state, local, and territorial levels. There's $10 billion to enhance the use of the Defense Production Act for purchasing and distributing key medical equipment and supplies. There's about $7.5 billion for community health centers for all sorts of activities around vaccine distribution, administration, contact tracing, et cetera. Another $7.5 billion to HHS for public health workforce issues that Dr. Hamburg was talking about, really everything from case investigators, contact tracers, community health workers, public health nurses, et cetera. An important $2 billion for genomic sequencing so we can understand and track the rise of variants. $6 billion for supply chain issues around the vaccine, $7.5 billion specific around the vaccine distribution, and then other focused areas for Medical Reserve Corps and Indian Health Service activities. Does it go far enough? Well, it not quite, but it's certainly a really critical start, especially at this point in the COVID-19 pandemic.
Thank you, Asaf. When we look at this, I'd like to first note, I mean, when you look at these numbers, this seems like an unprecedented surge of resources going into our health system and our public health capacities. Do you share that? I mean, this just looks like a massive shift of resources. Would you agree, Asaf?
Oh, absolutely. It's quite frankly, the massive shift that we needed last year, and we'll probably continue to need in a replenishment at some point later in the year or early next year as well. But it is unprecedented, especially in its focus on critical public health capacities, workforce capacities, in a system that I think has been stretched to its limits.
So this is an emergency provision, but clearly it goes beyond an emergency in terms of what the likely impacts are going to be. We're going to have an opportunity in the next couple of years to build off of this quite dramatically. But I'm expecting this, we're going to need to think about sustainable investments that reach beyond the scope of this emergency response. Peggy, how do you see that? We know that there's always this cycle of crisis followed by complacency and neglect. As we get out of the acute phase, as people begin to move towards normality, there may be a strong urge to move on and really not pay attention to what those long-term investments are going to be. Peggy?
Well, thank you. And you just made the point that I was on the edge of my seat wanting to contribute. We do need to think about sustainability. This is obviously a huge infusion of resources to address some critical needs at this moment in time when we're in the midst of a global pandemic and a infectious disease threat that has devastated our country in so many ways. But as we put this money to use, we have to both address the challenge that we're in the midst of, but we have to make sure that we are using it to also build, or in some cases rebuild, systems that are critical, that we use it to modernize approaches to problems, and that we are, as I said in my earlier comments, willing to take a hard look at what we need to reform in order to better address public health issues going forward. We also have to really work on those places of intersection with other critical components of a comprehensive health-based society, where we are addressing the critical need to prevent problems before they happen, as well as having the resilience to respond to the unexpected, as well as to known concerns. And I think we have to really take this moment to really try to keep health at the center of how we think about investments in this country, health and science, including the ongoing investments that are needed in biomedical research. There has always been a tendency to think that health was sort of an afterthought in many programs and policies. But what COVID has shown beyond a shadow of a doubt that it drives everything that matters in our lives, whether it's social cohesion, educational opportunities, the economy, our national security, and in fact, our international security.
Thank you. That gets to really the question of where is the constituency going to be over the long term for this type of sustained investment in public health? We know that the mission of prevention is one that oftentimes people do not see or recognize as terribly important. When you're successful, you don't see the bad things. You don't see the bad things that were averted. And we know that in the 2008 meltdown of our economy, that there was a severe disinvestment in staff and budgets across this country, and we never really recovered from that. Fully a third were pulled back. And now we have the opportunity, it seems, from listening to both of you, we have the opportunity for building a new coalition of interests that believe in public health as a major priority. Where would you see, Peggy, where would you see that constituency emerging at this moment in time?
Well, I think everybody that has had to grapple at a personal level, a family level, a community level, and a national level with COVID, I think has a renewed appreciation of how much health matters and all of the many ripple effects that come from threats to health. I hope that we also can have a renewed appreciation for the importance of science and data in driving our decision making and in our preparations, so that we can be the resilient society, so that we can prevent problems from happening in the first place. And as I look at COVID, it is just one of many challenges that loom before us, where we know we need to do more, and yet we're not responding. Climate change is, of course, the biggest challenge, probably, in terms of it's inevitable. We're already feeling the impacts of climate change and health, whether it's extreme weather events from tornadoes and hurricanes and flooding, to hot weather, to cold weather, to changing patterns of disease that make us more vulnerable for infectious disease outbreaks, like we're seeing, to food and water insecurity that results. So many critically important health-related problems from climate change, yet we as a society, are not really mobilized. It's almost like a pandemic unfolding in slow motion in some ways, in terms of the huge impacts on health and other things that are going to be enormously dislocating. And we need to really pay attention now, so that we can minimize effects going forward. Similarly, I think that the inequalities in health and access to health care have been sort of a slow burn to the health of our society and our country. Now that COVID has shown the light on this, I think we have an opportunity to really address it in fundamental ways, with a sense of time urgency. And I hope that there will be a constituency that is formed and continuing to expand around that set of issues and concerns as well, because it will improve health for all.
So in effect, the delivery of public health and health services becomes a form of social justice.
Indeed.
And that can generate a new coalition. Asaf, we've seen in this period foundations and private interests surge forward and do all sorts of creative things. Peggy and I were engaged in a conversation just recently with the COVID tracking project that the Atlantic posted, which is kind of a remarkable effort that sort of outstripped or outraced the public sector in a way, in terms of data collection and analyses. Do you see, Asaf, the private sector playing a bigger role in this transformation that we're calling for, and in which specific ways? And do you see new constituents coming forward, not just private sector, but also in media, in foundation world, at universities, as part of this shift of consciousness?
Well, I think that by virtue of the role that the private sector plays in the U.S., it will absolutely continue to play a massive role in two ways. We saw this in the era of COVID, which we're still in, but certainly early on, in very much a gap filling mechanism, because of the ways in which public health capacities and other capacities had not been supported and structured and funded enough. COVID tracking project, or a whole host of public-private partnerships had to come to the fore to literally meet the needs, fill these gaping holes. And that was necessary, and in many ways, some incredible work was done. I think that the other side of that discussion is that the fact that in some areas, the private sector can move faster, be quite innovative, be quite creative, disrupt in a good way old ways of thinking. And that's, again, one of the hallmarks of defining the innovative capacity of the United States. And certainly we also saw that with the ability to manufacture vaccines in record time. Incredible close connections and with the private sector, with NIH, the toggling back and forth between publicly sponsored university research, NIH research that's then picked up by the pharmaceutical industry, really an incredible case of breakthrough innovation. The question, I think, in hearkening back to what Peggy was talking about, is we in the US are really good at breakthrough innovation. and we pride ourselves and have a roaring economic base in large part because of that. We often have been less good at follow-through innovation, partly because our attention is focused on the new, on breakthrough, on the shiny and the things that have not been seen before, and partly because we have a blind spot about the need to invest in the follow-through innovations that get not only the things that we invent delivered to the last mile to all communities, but because it's just less exciting. It harkens to our often disinterest in investing in critical infrastructure, in making sacrifices and spending now for tomorrow. So for, in many ways, that's what's befallen part of our lack of interest in investing in public health, because it's been a bridge problem, right? I mean, you don't invest in bridge maintenance until bridges start collapsing and people get hurt and you can't cross the river and transportation is snarled. And I'm certainly not saying that public health is fuddy-duddy or just bridges, but in many cases, our challenge, especially with the private sector, is to help them understand that it's as attractive, as important, as remunerative to invest in follow-through innovations to help deliver vaccines into arms using new ways, or help make sure that communities have access to all the health enabling activities and technologies, as it is to invent them in the first place, or sponsor wonderful pilots or university-based consortia, or private sector-based technology companies. We need to rebalance breakthrough and follow through. We need to rebalance rescue and promotion and prevention.
Thank you very much. Peggy and I have been involved in some discussions around whether the time has arrived when we should give very serious consideration to having a 9/11 style commission, which could fulfill potentially some of what we're talking about, building a vision that's long-term, harvesting the major lessons of what have happened, building the case politically for a long-term sustainable set of investments and the like. Asaf, have you thought about this matter? And then I'd like to come back to Peggy and get her thoughts on the pros and cons and how do you move such an agenda? We have had the experience in 9/11 Commission, 2003 to 2005. Now, as we look back, a great success, changed America, changed our approaches to terrorism. Is something like that warranted in your views right now, Asaf?
I absolutely think it is. And I think it needs to be wide ranging and expansive, and not start, from November of 2019, when the first cases were possibly reported, but really go back to, decades of a lack of focus and a lack of investment in key public health capacities. And trace the arc of that in not a blameful or politicized way, but in a way that helps us understand that this is the opportunity to pivot toward a different investment architecture, both in the public and private sectors. One that actually, as we've talked about, we really don't have a choice not to invest, because other health shocks and pandemics will come. And we've seen so clearly the human cost and the economic cost of not making what are in the long term fairly paltry investment envelopes, given the size of the crises. So I really see this as an opportunity to take stock of what has been also just an enormous human and social toll, document that, get a plethora of perspectives, have a wide range in our arc from 20, 30 years before through the pandemic, and then forecasting 10 years out, to be able to say, let's do something different now. Let's invest differently now if we want to actually promote health and not just healthcare.
Thank you, Asaf. Peggy, what's your thoughts? What's in your view, what's the case for a 9/11 Commission?
Well, I think Asaf just made it pretty well, but I think, this was and continues to be, a huge catastrophic event in our nation's history and experience and for the world, and we need to understand it and learn from it. We have to look at the lessons learned for better and for worse, so that we can avoid repeating our mistakes. But importantly, we need to do this not to point fingers and blame, but, if I can quote our current president, so we can build back better, so we can make sure that we are really investing in systems that matter for health, and systems that matter for our society, our economy, our security, and our futures, and that we aren't just thinking about how do we get out from under COVID. We're not just thinking about how do we prepare against another COVID crisis, but that we also put it in the context of what is really needed to support health against other potentially catastrophic health threats, but also to better address our routine needs. And clearly, it was failures in our ability to respond, to be able to deliver on basic public health measures and healthcare measures over a period before COVID that further compromised us as we tried to rapidly scale up to address, a crisis of this size. So I think we really do need to take a serious look. The danger, of course, is that it's such a broad set of issues, and as you dig down, so complicated that one can get just mired in it all. So I think the challenge will be to really define some core areas that can make a difference, perhaps to do this kind of a COVID commission in parallel with some other activities, with different expertise and different partnerships, so that we can get a more comprehensive look. But I think this is absolutely essential. And as was just noted, this isn't the last time we're going to have to mobilize as a society and as a globe. And so we better learn some lessons, and we better make sure that we are better positioned for the future.
Thank you. As I was preparing for our conversation today, I was recalling this wonderful article that was in the New Yorker recently by Asaf's boss, Atul Gawande, who wrote a long piece about the politics and culture and deliberations that happened in Minot, North Dakota, around issues like masking and other behavioral dimensions. And the reason I bring this up is, in reading that, I came away thinking, I don't really understand what happens in most communities. Atul went and planted himself, and I think he arrived at some conclusions or some revelations that even he didn't really expect. And so, Asaf, do we know what's going on and how communities are responding to this? Did Atul sort of open a window into a different kind of a phenomenon that we need to understand much better?
He did. I mean, I'm a little biased, obviously, but Atul and I, we often talk about the privilege of coming. Both of us came from immigrant families and actually spent a lot of time growing up in the Midwest in smaller towns. And so I grew up went to high school in southern Minnesota, and he's went to school in rural Ohio. And I think that gives us a perspective that says at least the following, which is we don't actually understand, and we particular in all sort of the sort of politicized camps of the country, especially over the last year, often have caricatures of what different communities think and assume that communities have monolithic ways of knowing and seeing in the world. I'm reminded by a wonderful quote by the novelist Khaled Hosseini. He said, one is well served by a degree of both humility and charity when judging the inner workings of another person's heart. And I think that we emerging, as Peggy said, from this time period, and if a commission is to go forward, we'd be well served to have that degree of humility and charity, to understand it's not just about people who don't have enough information or, are too beholden to experts. It's really about, very situational, contextual, idiosyncratic workings, stopping a little bit, asking questions of curiosity, being open and less judgmental. Beyond health, we would do well to take that upon us in our next journeys.
Thank you. Peggy, your thoughts on what more we need to do operating with charity and humility, as Asaf has said, to better understand what is happening in communities and how they are understanding and acting upon these challenges?
Well, it's so important, and it's hard because you have to, really step back and listen and, not make assumptions about what people are thinking, what their priorities are, what their, assessment of a given situation may be. One of the great surprises for me as COVID unfolded was I thought if there was anything that would bring together a divided nation, it was something like a pandemic threat. And yet we saw how the political and ideological divides only deepened and affected the ability to actually deliver critical components of care and to achieve some of the essential components of a public health response that, mask wearing, for example, would become, a political issue, not a public health issue. So I think, we have to find a way to listen to each other and have fora for thoughtful discussions of complex issues. None of the problems before us have simple solutions, and they really require working, across sectors and disciplines and communities and borders, in fact. And we just have to learn ways to do a better job, whether we're addressing issues of health or other of the challenges that confront us. And I loved Asaf's reflections on the importance of humility and charity. I guess I would add another word, if we could, about a sense of solidarity as well. We really have to recognize, that we are really all in this together. And, it's not just because we're talking about an infectious disease, it's talking about the fact that we live in communities and a country and a world that just has, so many interconnections and interdependencies, and that, we really cannot afford to keep going down this route of divisiveness and, a failure to be willing to try to put yourself in others' shoes and to try to bridge differences and conflict.
Thank you. I want to pivot to the question of what is happening across this country in many legislatures. It's not unlike what we're seeing in the debate over elections. What we're seeing is debate in legislatures to reduce the authority of public health officials. And it's tied to this reaction that we've seen in many communities, and where the debates over masks have pushed towards an emphasis upon liberty and lots of active hostility, if not active assault upon public health officials. We've had trauma, we've had resignations. The professional field itself is saying they anticipate when we get out of the acute phase that we're going to see a massive exit from the profession because people are fearful, they're exhausted, they feel humiliated and abused in this period. So we do have, in many places, this very difficult battle going on in which public health has been sort of presented as the antithesis of liberty somehow. How do we get out of that, do you think, Peggy? How do we work our way beyond what this legacy of politicization and polarization that we are seeing in many communities?
Well, it is tough. I mean, these jobs have always been hard, and public health officials have to make difficult decisions, especially in the face of a crisis. But generally there's an appreciation and support for what needs to be done, because there's a recognition of that common goal, the common good that we're trying to achieve. And here, I think we all see that common goal, yet the divisiveness, the finger pointing, and the viciousness toward public officials, as you've noted, has been extraordinary. And I wish I knew the answer. I mean, I think that the part of it is that there is so much good work going on and people can see it and appreciate it. Look at the support around some of our critical public health leaders, including Tony Fauci. But the other side of that is, I don't think he ever expected to face the kind of threats and personal attack that he's had to live through of late. But I see it as a broader social problem that we have to figure out the answers for. But I am afraid I cannot offer you a clear illumination of the path forward.
I mean, Asaf, I want to turn to you for your thoughts on this. It seems to me that we have to redouble our efforts to be very supportive of our public health officials. We need to be very actively trying to bring down the temperature and cool things and turn people's attentions to a forward look on what we're trying to create that benefits the communities. We need to celebrate the value of these officials and what's being created now in this next phase, and we need to offer better protection in some ways. These are officials who are acutely vulnerable, and we underestimated their vulnerabilities in some respects, that they have gotten caught in the crossfire of a culture war of a kind, and they don't deserve that. And if they do disappear, we're going to pay a huge price for that. Asaf, what is you're living and interacting across this whole spectrum of different relations in your work with people who are working at the local and state level. What are you seeing, and what do you see as the path?
Well, I'm a realist and I'm an optimist. So I, in that vein, so I teach at the Harvard School of Public Health, and what we're seeing is really interesting. So all of the sort of miserable experiences that you're discussing notwithstanding, and this is not just for Harvard, but across the nation, we're seeing a near doubling in applications for people going into the public health fields, whether that be master's or doctorate degrees. So, and by the way, we see that in other healthcare professions too. I mean, I think that younger people have seen the sense of collective service and duty and the beauty in the sacrifice that people across the health professions have made in service of something bigger than themselves, and find that inspiring, and find that they want to bring their best ideas and talents. So that makes me optimistic. Now, we seem to not be able to have very much of a social compact to even have many basic discussions. And, the many public health leaders have had such negative experiences. I guess what I would say to that as an amateur historian, underline the amateur, is that's part and parcel of our American experience. I mean, 300 years ago in the town that I sit in right now in Boston, there was a major outbreak of smallpox, and there was a huge debate between the clergy and governor leadership and, proto-public health practitioners who actually learned about variolation and inoculation from a slave named Onesimus, and used it after much debate and consternation. And actually the debate launched a printer's career named Benjamin Franklin, who wrote about this debate, and he would go on to do a few other important things. But that debate was as nasty, and people were beaten, and physically and virtually, and it was awful. And 100 years ago, there were literally in San Francisco anti-masking brigades that went around and beat public health professionals. Now, that's not a positive, but I guess I look back on it and say, this is part of a centuries-long tension in and around public health between notions of collective good, service, and responsibility, and variations on themes of individual freedoms, including the freedom to do things that are bad for people and bad for communities. We have an opportunity not to solve that, but to make that previously under-visible gap more visible, put it out in the community and say, at the end of the day, everything exists on a spectrum, and there is more area to compromise and to respect and to move forward and to, yes, honor freedom, but also also prevent and mitigate horrendous pandemics. And I actually trust in most Americans across the spectrum to do the right thing most of the time. So, and in young people.
And when you think about what happened during COVID, it was incredible how people mobilized to do the non-pharmaceutical public health measures they were being asked to do, totally unexpected in their previous experience and expectation to be having to shelter in place and social distance and wear masks and not go to work or large gatherings or send their kids to school. Also, in a setting where there has been concerns about vaccine hesitancy, I think we are now seeing people, really moving towards acceptance of the vaccine as they see that the science was done in a careful, thoughtful way without cutting corners, that the vaccines actually are safe and effective and can make a difference, and that government and industry and the academic sector all work together to make this possible. And that now, as opportunities to get vaccinated are increasingly available, more and more people are actually shifting from a skepticism or reluctance to wanting to receive it. It won't be everyone, but I think it's an example where, we're moving forward in positive, constructive ways to do the right thing, have brought people along with them. And I think it's restoring people's faith that government can work in a leadership coordinating role as well.
Thank you.
I agree. I see that on a daily basis, working with patients and I work with communities that do have a lot of vaccine hesitance. But hesitance is a spectrum, and most people aren't completely hesitant, and there is an opening, and it takes time and trust. And I think that's the David Leonhardt had a very important article this week about negativity in our discussions of the big discussions and the data, and we have a negative bias as humans to we want the things that appear negative, we get more attention. There have been so many negative things obviously about COVID and the vaccine rollout, but the story actually right now is emerging and arcing toward positivity. And it's important that we see that and see, yes, there have been all of these, in this discussion of public health officials, all these challenges, but most people stepped up, did the right thing, and are continuing to do the right thing, and we're heading in the right direction.
Thank you. I just want to mention CSIS has been a partner with the London School of Hygiene and Tropical Medicine. I've co-chaired with Heidi Larson a high-level panel on vaccine confidence and misinformation, and we've drawn heavily from both of you in the work of that panel, and we'll be publishing at the end of April, early May, the final report of that. And we have acknowledged the dramatic gains made. We've also highlighted that we still have considerable work to do. And this week was a big week in terms of testimony on the Hill, increased, continued high demands for the major social media to begin to exclude the top dozen, what are seen as the top dozen individuals who are leading in the anti-vaccine movement. We know that Republican men now, it's been substantiated, upwards of 50% are claiming they will refuse the vaccine. We need to focus on that population. There's obviously been a big mobilization around the equity and disparities issue and hesitancy within the Black community, Hispanic community, Native American, and special focus there. There's still a lot of work to be done here, I think, is in getting people to come forward. We've got fully 30% of our population that's still a bit on the fence, asking very legitimate questions that need to be answered in a respectful way. What more do you believe, Asaf and Peggy, what more do you believe we need to do as a country to really bring forward much greater acceptance of vaccines? Because we are not going to get to 80 or 85% coverage in this country with the current resistance that we see.
Well, in this, I mean, you and I have talked about this before, Steve, but in these months and moments that we are in now of high demand and low supply, we have understandably focused on operational efficiency, on mass vaccination strategies, on big communications, and on, you know, getting the widgets right to get a few thousand more vaccines in every vaccine center. And that's important. And that's going to get us to 50, 60% of the population. And then by the end of the spring and the summer, this long tail, this last mile of, you know, pockets and communities, again, with legitimate questions and concerns, that I don't see a way of getting that to the last mile without really the retail strategy. We've been focusing on wholesale, but now it's time to focus on retail. When demand decreases but supply increases, this is going to take conversations with trusted arbiters of communication and information in and around communities that have the most questions and doubt. And so I am more interested and more supportive of a retail strategy that focuses on, you know, faith-based leaders, community leaders, small community clubs and gatherings where people can ask their questions. Again, most people, and I've been doing a lot of clinical and public health work, most people who are hesitant are not completely hesitant, i.e., you know, I will not do anything. They have questions that take time and care and empathy and skill to answer, like any behavior change. That will happen in and around primary care. It will happen in faith-based communities and other small settings where people can see their peers get the vaccine, see that nothing bad will happen, and have their questions answered. That's going to take a lot of time, effort, and resources. And I think we need to start shifting that strategy to one that answers the questions of low demand and high supply.
Thank you. Yesterday or this week, there was a version of The Daily with Apurva Mandavili from the New York Times, and she was speaking about hesitancy, and she was speaking about this phenomenon of half of Republican men claiming they were not going to take up the vaccine, and tying that to the legacy of very conflicting messages coming in the Trump era to those staunch supporters of President Trump. And so we now see it's increasingly visible, this problem that we face with that sector of our population. Peggy, what do you think the strategy should be in trying to engage that community in a very constructive way to try and bring them around to see the value of vaccines?
You mean specifically the Republican men? Or
Yes. What would be the strategy? And we haven't been focused so much on that as a key challenge, and it is a key challenge.
It is an important challenge, and I think that while a different subpopulation, some of the same lessons apply, that it's not just a question of trying to say, if you don't want to be vaccinated, you must not understand the facts, you must not understand why it matters, but actually trying to listen and hear their concerns, but also identify their role models, people that they identify with, and try to engage them to help with spreading the message and encouraging vaccination. I mean, I was heartened that Trump did publicly indicate that he'd been vaccinated and that the vaccine was good. Sort of surprising he wouldn't take more credit for the vaccine, since it was, an effort that was really made possible during his administration. But it would have been great if he had actually done it on camera as well.
Right, right.
But I think that's the way to get at it, or otherwise you sometimes inadvertently push people into more extreme positions if you try to approach it in a patronizing, we know better than you
Correct.
kind of way. So whether it's, middle-aged Republican men or communities of color that have learned to distrust aspects of our healthcare system, we need to be identifying where are their trusted sources of information. We need to respect their concerns and listen to them, and we need to sort of broaden the number of players who are helping to advance vaccine efforts.
Thank you. It is true, former President Trump spoke at the CPAC meeting in Orlando and encouraged his supporters to take up the vaccines. And subsequently, when some of this new survey data came forward, he spoke up again. And I'm hoping we'll hear more, and that from the Republican Party leadership and elected Republican governors and representatives and the like, that we'll see a more outspoken advocacy that will, I think, begin to change the climate. Let's close by asking each of you, you've said a lot to us already about how we need to see the gains and be optimistic and look forward. Let me just ask you to close briefly, each of you. We'll start with Peggy and then Asaf. What gives you the greatest hope and the greatest optimism today, the greatest strength in looking to the future as we move out of this acute phase?
Well, I guess what gives me hope is that I have seen that even though it's been bumpy, we have been able to mobilize to both harness the science and expertise needed to address the challenges before us, but also to undertake some things that have been very, very hard, including the social distancing and the terrible devastation to our economy and way of life that responding to COVID has brought with it. I see, many people, big and small, that have acted heroically as we have struggled to address this. But I am concerned. That there are many trends that are hard to overcome, as we've been talking about, in terms of the divisiveness and the insertion of politics and ideology into efforts to address, what is really, a shared problem of an infectious disease threat. I'm also concerned about what you raised earlier of the cycles of crisis and complacency, and that once we get through this, people will want to move on and put this in the rearview mirror. People will say, well, that was bad, but look how quickly we developed a vaccine, look how we were able to get the economy back on track. So, not to worry. We have to recognize our vulnerabilities, and we have to address them as we think about, the future of healthcare and public health, and as we think about, the future of our nation and our place in the world.
Thank you so much. Asaf, you get the last word today.
It's hard to follow Peggy. I'm so hopeful about, as she said, the science and our ability to, in record time, create not just vaccines for this problem, but platforms for future problems, future potential pandemics. That's exciting. I am buoyed by my fellow healthcare workers, their incredible resilience. I just spoke to a group of medical residents, and if anyone doesn't have faith in large sections of young people kind of coming up through the ranks in different professions, you should just go talk to young nurses, young residents, and what they have done on the front lines through almost unimaginable circumstances is really a testament to them, and a testament to people's innate general goodness and ability to cope with the unimaginable. The issue of imagination, I actually want to say, is both a hope and a risk. one of the key failures that we haven't really talked about so much with COVID-19 is our inability to imagine something that none of us have really ever seen. Exponential increase in a respiratory pathogen that, and you could watch it in February and March. And this was the problem, that in many ways our delays were delays that were very understandably human. We couldn't imagine what we had never seen before. So what's the lesson from that? And what's the hope? Well, the hope is that perhaps through all this misery and suffering, and finally seeing the unimaginable come true, we have the capacity to imagine, not in a sort of overly depressing or negative way, but in a sober way. We imagine and clearly state before us the crises that could happen, whether they be infectious pandemic or climate or nuclear threats or other massive threats that have almost, this kind of storybook horror attached to them. And it's easier to just be complacent and just say, that's just what a few worrywarts think about. Well, we need to face those. And I think that COVID gives us a platform and an opportunity to be able to face that if we choose to do it. So the opportunity here is, because Peggy and I and you, we were in meetings after Ebola in Geneva, in Washington, and everyone said, oh, we've learned our lesson. We know we need to be prepared pandemically, et cetera. And we saw what happened. So I worry about that, but I also think that now that we've seen the almost unimaginable, maybe we'll be able to break out of that cycle finally.
Thank you. Before we close, I want to offer a special thanks to my colleagues who pulled this all together: Kate McPhail, Madeline Clough, Graham McGillivray, Amith Mondavili. Thanks to all of you for pulling this program together. A special thanks to Dr. Hamry for blessing this initiative, which is a new outreach by CSIS. And I want to thank especially Asaf and Peggy for coming and sharing your insights with us this morning for what was really quite an extraordinarily rich conversation. And I want to thank you for all the other contributions that you make in this world every day through your leadership and your brilliant interventions. So thank you all.
Thank you.
Thank you so much.